Bismillahirrahmanirrahim. Assalamu alaikum. Dear audience, today our topic of discussion is about vitreoretinal surgery. Yes, I'm going to talk about pneumatic retinopexy, a very effective way to treat retinal detachment surgeries. Our guest speaker today is Dr. Umar Al-Nahrawi. He is a deputy director and a senior vitreoretinal consultant at Klinikum Stuttgart. The hospital is Catherine Hospital, Germany. Dr. Umar Al-Nahrawi has got extensive experience in doing vitreoretinal surgeries. He has done all types of surgeries, complicated retinal detachments, scleral buckling, macular surgeries, almost 6,000 to his credit. We are honored that he has accepted our invitation to guide our audience about this procedure, which has been very effective since 1980 and an effective tool for the VRAR surgeons all around the world. So without further delay, I will ask him to please present his talk.
Okay. Hello, everybody. Assalamu alaikum. Nice to be with you today with my topic, pneumatic retinopexy. Just a little bit about the history. It was historical that air was injected 1911 through Ohm to treat retinal detachment. Then Rosenberg has tried to make a drainage for the subretinal fluids and use air also to treat retinal detachments. Then 1973 tried Norton to use SF6 for as an addition for scleral buckling to inject SF6 to increase the rate of successive retinal detachment. Then Hilton has introduced the term pneumatic retinopexy in the American Academy of Ophthalmology. Pneumatic retinopexy is just an easy maneuver, but very effective to treat retinal detachment. Just you make the retinal cryopexy, or you just inject the gas bubble inside the eye and make later the laser retinopexy. I like to combine the cryopexy with injection of gas bubble on the same setting so that the patient have his full treatment in the same setting, and I do not miss the exact time of delayed laser retinopexy. You see that through pneumatic retinopexy, you don't remove the traction and you don't remove or close the hole through vitrectomy and not through scleral buckling, but Linkov and Kreisig has shown that you don't have to remove the traction. You can just make a scleral buckle, and they have made the balloon buckle. This balloon buckle, just you put on a buckle in on the sclera for about 7 days. Then you remove the buckle again, and the patient is treated. So you don't have to permanently treat the traction on the vitreoretinal traction on the whole. The indication is on cases of superior breaks or one break or multiple breaks within about 2 or 3 clock hours, and the patient who are compliant, who can make a good positioning of the head to treat the hole. You can do it also as an addition for scleral buckling, and you can do it in cases where the buckle is not feasible. When you have a young patient, you want to treat him, and you don't want to make a vitrectomy because of the lens and because of the PVR reaction. This is a good option. The the patients who are not good candidates for pneumatic retinopexy are the patients with inferior retinal breaks or PVR or vitreous hemorrhage, so that you cannot assess all breaks, or patients with lattice degeneration or large holes or multiple holes in more than 2 or 3 clock hours, or the patient of physical or mental disability who cannot cooperate with you to halten a position to close the hole. And if the patient need to travel shortly to have a flight, so you are not allowed to inject the gas inside the eye. The surgical technique, just to you make the cryo treatment first so that you have made massage for the eye globe, then you make the cryo treatment, then you make paracentesis to just to get a little bit the eye softer and make a space for the injection of the gas. And you use SF6 gas about zero point 0.6 milliliter inside the eye. Then you make a fundoscopy and you make sure that the retinal artery is pulsating, everything is okay. Now the question, which gas? Some people perhaps use air, but this is very seldom. I haven't seen it only perhaps as an addition for scleral buckle, but the standard is 6 because it doubles its size within 1.5 days. That is what you need. Uh, um, Fast reaction, fast and large gas bubbles. This C3F8 needs about 3 days, and then it stays unnecessarily long inside the eye. The function of gas bubble is to isolate the hole from the vitreous cavity and close the hole. Through the surface tension of the gas bubble, you can close the hole. And here, after the operation, you have to tell your patient perhaps to make a steamroller maneuver. Just I show the patient elevates his head. He have a face down position at the first, and then every about half an hour to 1 hour, he makes 30-degree up. So in about 2 to 4 hours, the patient has an upright position. Some problems can perhaps happen during making pneumatic retinopexies fish egg so that you have small bubbles instead of having one large bubble which have a surface tension which makes the job. These small bubbles perhaps does not make the job that you want, does not flatten the retina and can go through the retina. So when you have gas under the retina, you have a problem. You have to immediately go inside the eye and do the vitrectomy because if you have a gas bubble wandering under the retina, you have a total detachment within pair of minutes or hours. The post-operative monitoring is in day 1, day 3, week 1, and week 2. You have to very closely monitor this patient because you want to see the success. You have to look if the patient have new breaks, and if you have to go with a vitrectomy, you have to go in the right time. Is still pneumatic retinopexy an option for treatment of retinal detachment? Because some people says it's obsolete. We can see over decades that the tendency of vitrectomy is increasing and the tendency of scleral buckle is decreasing. Even some hospitals are don't do scleral buckle anymore. But the rate of treatment of pneumatic retinopexy in the USA is still the same. The success rate of pneumatic retinopexy in much reports is very high in much reports in about 4,138 patients from the first operation or the first injection of the first gas bubble is about 75%. And with a top-up bubble, you have a rate of success about 96%. It's very effective maneuver. And if you compare pneumatic retinopexy versus scleral buckle, you can see that pneumatic retinopexy have a lower post-operative morbidity because the patient can go home in the first day. He doesn't need general anesthesia. And the post-operative visual acuity of scleral buckle to just to get about zero point 0.4 vision is in scleral buckle is in pneumatic retinopexy higher than scleral buckle. And the retinal apposition rate is very high. And after a reoperation, there's no statistical difference between the success rate in both groups. The pivot study, which was done through Rajiv, this is the man who is leading the idea of application of pneumatic retinopexy in every patient till proved otherwise, mostly the patient with simple detachment. And the pivot study has shown that the vitrectomy has perhaps a higher success rate from the first operation, but pneumatic retinopexy have higher visual acuity and lower cataract rate. And you can see after the second operation that pneumatic retinopexy and PP uh, pars-plana vitrectomy has the same rate of success rate. The patients with pneumatic retinopexy have better visual acuity, better quality, lower macular folds, and lower rate of metamorphopsia. This is because When you fill the vitreous cavity totally with a gas bubble, perhaps you have displacement of the retina, but it doesn't happen in pneumatic retinopexy. Cases which are advantageous with pneumatic retinopexy, as we said, the holes are superior, it's a simple detachment, they are small holes. If you have a patient with glaucoma and you don't want to make a distortion of the bleb, then it's better not to put the trocars and to suture the sclerotomies so that you'll have to destroy this bleb perhaps. In a patient with a high bolus detachment, you go for vitrectomy or you make pneumatic retinopexy. Here, scleral buckle without drainage is not a good option because the opposition of the retina to the scleral buckle is difficult. If you have posterior breaks or if you have a redetachment after a scleral buckle. So pneumatic retinopexy is advantageous. Don't do pneumatic retinopexy in aphakic or pseudophakic patients because they have sometimes multiple holes. The holes are near the aura or very wide and anterior. So vitrectomy is better here. Multiple retinal tears or detachment involving more than 50% of the retina. So these are the advantages of pneumatic retinopexy. As vitreoretinal surgeon, you offer the patient three kinds of treatment. We say good and cheap. This is the buckle, but most surgeons need about 30 to 40 minutes to do a clear buckle. Fast and good, but not cheap. This is the vitrectomy, about 20 minutes. You can treat a retinal detachment. Cheap and fast, but it will be good. This is the pneumatic retinopexy. If you see buccal complications or myopic shift after encircling band or astigmatism or diplopia after scleral buckle, or if you see an aggressive PVR reaction after very simple detachment and you don't know why, perhaps pneumatic retinopexy. I just wanted to add at the end some examples. This is the first example, 33 years old man who had here a hole, and I have treated him with a limbal buckle, and everything went okay. Everything was perfect. The patient satisfied. He came up, but after the operation, I have asked myself, why didn't I do pneumatic retinopexy? I don't even need this buckle. Everything went okay, but I could even treat my patient with pneumatic retinopexy. The patient came with the other eye 2 years later, and I did pneumatic retinopexy, and it worked perfect. The patient was satisfied with both eyes, but the treatment facility for pneumatic retinopexy was easier. This is a patient, also 52 years old with zero point 0.4 vision. I just did pneumatic retinopexy because I had a very busy operation schedule and I didn't have time for the patient. I made pneumatic retinopexy in about 10 minutes, and the patient had in the second day 0 point vision. This is the patient with 100% vision uh, um, 5 weeks later, and this subretinal fluid will go away. This is another example which was treated with pneumatic retinopexy. If you see such subretinal fluid, it needs about pair of weeks, even pair of months, about 4 to 6 months to go away. This is the patient, even with all the detachment, even with subretinal strands that you can see here, and he had a vision of 0.05. I treated him with pneumatic retinopexy. 5 days post-operative, he has reached vision of zero point 0.6 even with subretinal fluid. I think this subretinal fluid is like CSR subretinal fluid, so that the retina have tolerance for such closed fluid. And 9 months later, the patient have 1.0 vision. I just wanted to show this was a patient with a metallic foreign body in the retina. He was 19 years old, and I wanted to treat him like my brother. I didn't want to remove the vitreous. I made this maneuver. I just will show you this video, and then I've gone inside the eye without vitrectomy. This only chandelier light. This was a little bit exceptional and non-routine maneuver. But it was my idea. I have measured the foreign body. with the Eckhart forceps, and then I made this sclerotomy and I removed the foreign body with a shake hand technique, and then the foreign body is outside of the eye. Then I had the problem. I have a hole, and the hole is standing up, and the vitreous is there. And then you can see that I have lasered the hole, and I have thought, shall I still do the vitrectomy? Then I came to the idea I will do pneumatic retinopexy. I have done it even with air, and this was the result of the patient. Excuse me, just have to get out this slide. And this was the result in the first post-operative week. And this was 6 months post-operative. He has his own vitreous, he has his own clear lens, and the pneumatic retinopexy saved my plan. And as the people of refractive surgery says, back to the surface, with PRK, we say back to the bubble. Thank you. Take home message, pneumatic retinopexy can be in your instrumentarium. Thank you so much. I don't hear.
Well, Dr. Umar, you have explained this technique of pneumatic retinopexy with different examples beautifully, particularly when they are associated comorbidities like glaucoma, intraocular foreign body. I have a question regarding this, that you have done almost 5,000 posterior segment surgeries, and now people have gone towards small gauge vitrectomies. What do you think about the future of this pneumatic retinopexy technique?
I think small gauge vitrectomy has only the advantage to make very small sclerotomies so that you don't have to suture them after the operation. It doesn't have any other advantage. So we make also 23 gauge without sutures also on 25 gauge. The 27 gauge, I don't like to use it because I have a sutureless vitrectomy even with 23 gauge.
Dr. Umar, the thing is, of course, it is a cost effective and relatively minimal invasive procedure, but there are higher chances of redetachments as compared to pars plana vitrectomy or scleral buccal. What is your point about this? What is your opinion?
That's right. That's why my rate of pneumatic retinopexy much lower than retinal detachment. If I do in a week or in a month about 35 uh, vitrectomy, perhaps I do one pneumatic retinopexy or perhaps every 2 weeks because I select my patients. You need a success. You don't need to just to do pneumatic retinopexy for every patient. You need to have success with your patient. So I make a discussion with my patient. I tell him what I'm going to do, and I do it only for round holes or very tiny uh, horseshoe-shaped tears. If you have a big tear, so you have the risk to have the bubble in underneath the retina, and I do it for young patients who have a clear lens. If you have a patient who is 25 or 30 years old and you don't want to remove the lens, if you make a vitrectomy, the lens will go opaque and you will have to remove the lens. It's not wished for a 30 years old or 27 years old patient. So I like to make in these patients scleral buckle or pneumatic retinopexy. If I have a large tear, I do a scleral buckle. If I have a tiny tear and not much subretinal fluid, I do pneumatic retinopexy. So that I have a high success rate from the first operation. I have nearly more than 90% success rate in my pneumatic retinopexy because I make a massive criteria of selection in those patients.
Right. Right. Well, Dr. Umar, sometimes surgeon does surgery with this procedure, and there is high intraocular pressure. And we know there are more chances of PVR, epiretinal membrane formation, and subretinal gas. So, how do you manage these things? Plus, if a patient develops redetachment after your pneumatic retinopexy, will you again go for pneumatic retinopexy or you will find other interventions like buccal or PPV?
First, the patients does not show higher rate of PVR if you select the criteria. You will have a success rate and the hole will close. So the cause of PVR is normally that the patient gets redetachment, goes home, and comes to you 1 week or 2 weeks later. So he will develop a PVR reaction. But if you monitor your patient and look in the first day that you have a very good gas bubble, the hole is closed, and the retina is attached in the first day, there is no cause to get a PVR. Secondly, if you and if you follow this criteria, very small holes, so you will have a high rate of success. If I see that the hole is closed, but the gas bubble is small, and the success rate is a little bit perhaps gets low because the gas bubble will go away fast. I put a top up gas bubble, but this is in a one condition. I see that the first operation has succeeded, but I'm afraid that the gas bubble it was a small and it goes away very fast. So in my criteria, in my own criteria, I have to succeed. I have to get success in the first day. Otherwise, I go for vitrectomy. And as I said, I don't do it for every patient. I do it for young patients where the lens wanted to be saved. Your last question was?
Last question was this subretinal gas formation, epiretinal membranes coming. How do you anticipate and manage these
Subretinal
things?
gas, I had it once as I did it for a patient. It doesn't matter how large is your detachment. It matters how large is your hole. I did it once for a patient with a little bit large hole and the detachment was very small. So I thought, okay, it can work, but the gas bubble caused traction on the vitreous and went underneath the retina. So I don't do it anymore for large holes. If you do it for very tiny holes, you don't have a chance to get gas inside underneath the retina. So
Right,
it's an exclusion criteria in my patients.
right. It is about a gas procedure. You put gas and then apply laser or cryo. The positioning is, Dr. Umar, very crucial in this. So face down position. But if the location is different, do you go for alternate positioning of the face? How do you consult patients and guide them about this post-operatively?
Start with face down position so that the gas will tamponate the macula and get the fluid away from the macula to the periphery, and it has a chance to get the fluids outside the hole. Then the patient will position, this is for about 4 hours, and then the patient will position accordingly where the hole is. If the hole is temporal, so the patient goes for on his nasal side and vice versa.
Right.
So I don't do very meticulous steamroller position.
You know. Okay. Uh, But this procedure, Dr. Umar, pneumatic retinopexy has relatively high failure rates in myopes or pseudophakics. What is your approach about these patients particularly?
I don't like to do it in pseudophakic patients because the patient is already pseudophakic and there is no disadvantage to go with vitrectomy. I do vitrectomy better in those patients, and then the holes are somewhat far in the periphery and in pseudophakic patients through the rim of the IOL. Perhaps you cannot assess the whole situation very meticulously. So I don't like to make pneumatic retinopexy. And as I said, pneumatic retinopexy is just not to remove the vitreous, just to save the lens so that the young patient, has his own lens to the next year to have a natural pacifying process. And so I don't do, and in high myopes, if the patient is young, the high myopes have much round holes with an attached vitreous, and they have a liquefied vitreous cavity and syneresis. So you have a big place to give even 1 milliliter inside the vitreous cavity, and it works perfect. And I have never have a redetachment rate in high myopic patients. As I told you, I do it for small holes, round holes. There's no chance to get gas under the retina, and you can give a very big bubble in those patients.
Well, Dr. Umar, you have explained this procedure and its limitations and how to manage and associated comorbidities beautifully. We know that you are one of very experienced surgeons with 5,000 surgeries to your credit. One last question. Many people believe that this pneumatic retinopexy is surgeon dependent success rate I'm talking about as compared to pars plana vitrectomy. What is your point about that?
Think it is more decision dependent, more than
Okay,
surgeon dependent.
okay, okay,
I let my young colleagues doing it. He
okay.
has to just make paracentesis, give the gas, and make the cryo treatment, and perhaps again go to the paracentesis because sometimes the fluid accumulates from the posterior segment to the anterior chamber again, especially in high myopic patients, so that you have a chance to re-drain through the paracentesis to have more place for the pneumatic retinopexy. Everyone can do pneumatic retinopexy, in my opinion, just to make a good cryo for the holes. Even you can make a laser treatment after that, but it is decision dependent. You have to make criteria selection just to have a high success rate because this operation, if you do it for every simple detachment, you will not get a higher than 50, 60% success rate. If you make a very strict selection criteria, I had for a while even 100% rate for about 2 years of doing this maneuver. Then I have seen two cases with redetachment. So I can say if you get the selection criteria, you will have success with your patients.
Very right. You are absolutely right that we can. This can be the take-home message that this surgery is selection dependent. Proper selection of the patients is very critical in the success of this technique. Well, Dr. Umar, I want to thank you. I know you are very busy with your schedule and your surgeries, management, research, administrative. You're also deputy director, head of department. I know you have so many administrative responsibilities, but in spite of this, you gave us time, you accepted our invitation. So I want to thank you on behalf of my audience, on behalf of my channel, and all those who will get benefit from your talk. Thank you, Dr. Umar, and we are looking forward to more lectures from you in future also. Thank you.
It was my pleasure. Thank you so much for your effort.